Good morning. This is David Henry. I'm the Communications Manager for the City of Amarillo. I want to welcome everyone for today's public health update for the Amarillo community. Let me go ahead and quickly introduce who is on our panel today. We are joined by Casey Stoughton, Public Health Director for the City of Amarillo, Dr. Todd Bell, Public Health Authority, Texas Tech University Health Sciences Center, Dr. Brian Weiss, Chief Medical Officer for Northwest Texas Hospital, Dr. Michael Emmentier, Chief Medical Officer for BSA, Dr. Rodney Gonzalez, Director of the Amarillo VA. We'll go ahead and start with Casey, and then we'll take questions from our media here in attendance. Casey, how are you today?
I'm well, Dave. Thank you. And good morning, Amarillo. We're glad that you could be here today on this nice, wonderful Wednesday morning. Hope you had a safe and healthy holiday. Glad you're back. Our team has retooled our press conferences to be a public health update. And so right now we are talking about COVID-19, but we will have this tool to communicate other public health information in the future. So it'll, right now we're talking about COVID, but again, we'll have other public health topics of interest in the future. So we'll start with an overview of the numbers from public health and then hear from our physicians. And I do want to take a moment to thank our physicians. This team of doctors has been on the front lines since the beginning of the pandemic. And so I just want to say thank you to each of them for their hard work and their dedication to our community. So as of today, we have a total of 59,737 cases of COVID-19 reported in Potter and Randall counties. We currently have 5,944 active cases in our community, and our community has experienced 1,033 deaths from COVID-19. The 5-day new case average from COVID we're currently at 619 new cases per day. And our 7-day rolling positivity rate for the community is at 19%. The positivity rate at the drive-through testing site is currently at 52%. So just over half of all people tested at the drive-through testing positive. Currently, the GA34's hospitalization percentage is at 21.81%. That means that just right under 22% of everyone that's in the hospital has COVID-19. We're seeing large numbers reported each day, large numbers at the drive-through, and large numbers at our hospitals. Prevention of COVID-19 remains our best tool in this pandemic. On Saturday, the Amarillo Regional Infusion Center used its final doses allocated of the monoclonal antibodies. We still anticipate the arrival of additional medication, but we currently have not received that medicine, nor have we received confirmation of its arrival. Please stay tuned to local media and local social media, or the city's social media account, for announcements of arriving monoclonal antibodies. And please, please, please wear your mask, get your vaccine, stay socially distant, stay home, all the things that we've talked about for so long. We have updated the Amarillo Alerts website, amarilloalerts.com. So there's additional information, additional guidance, updated the information about the CDC's new guidance on isolation and quarantine, which Dr. Bell will talk about with us today. And so please check out that website. There are a lot of information and guidance that can answer any questions that you might have. Our drive-through testing site is still open, as is our vaccination clinic. Our vaccination clinic for COVID-19 is a walk-in clinic, so please come see us. The drive-through testing site is available each day by appointment, so please call 806-378-6300 if you need to be screened and directed to the test site. That's all I have today, Dave. Thank you.
Thank you, Casey. Let's now go to Dr. Todd Bell, Public Health Authority, Texas Tech University Health Sciences Center. Dr. Bell, how are you?
Doing well. Good morning, David, and everybody. Appreciate the opportunity to be here. So I wanted to highlight a couple of things. And first of all, no surprise to anyone, we do think that virtually all the coronavirus that we're seeing currently in Amarillo is Omicron. We still don't have the sequencing confirmation on that I'm aware of. But when we look at some of our other ways of being able to look at what it's called presumed Omicron, there's a distinct signature that we see on some lab tests, and upwards of 90% of our lab tests are coming positive with that distinct signature. So if anybody has any question of whether this is Omicron or Delta, this is Omicron, and we just wait the official confirmation of that. I was going to actually mention, as Casey had said, or talk just a little bit about the new CDC quarantine and isolation guidelines. As a reminder for the purists out there, isolation is what happens when you've tested positive. Quarantine is what you do when you're exposed. Frankly, that the semantics probably don't matter too much as long as people know what the right thing to do is. So the CDC changed their recommendations in part because Omicron does tend to move both through a community faster as well as through an individual, perhaps a little faster than what prior variants did. They changed their recommendations so that if somebody tests positive for coronavirus, then they should, first of all, they need to isolate for 5 days. So they need to be at home. They need to be staying at home. They don't need to be going out or exposing other people. They know they're positive. They need to be at home for 5 days in isolation. At the end of that 5 days, then they can come out of isolation if they have been afebrile, so no fever for 24 hours, and their other symptoms are improving. Now, it's encouraged that they also be tested at that point to see if they are positive with an antigen test. And if they're positive, then kind of like the groundhog on Groundhog Day, they go back into hiding for another 5 days. If they're negative, then they can come out of isolation, but they should still wear a mask for an additional 5 days. Now, if people are unable to be tested at that 5-day mark and they're doing better clinically, they can come out of isolation after 5 days, but they need to wear a mask for an additional 5 days. The majority of spread seems to occur within the first 5 days, but people can still transmit the virus in the second 5 days. So if you're infected with coronavirus at this point, we say stay home for 5 days. If you're doing better, you haven't had a fever, then you can come out as long as you wear a mask and are diligent about masking. All right, what about people that are exposed but not yet infected? Well, if someone's been exposed and they're unvaccinated, then it's basically the same as if they had the infection. We ask them to stay at home for 5 days. That's if they've not been vaccinated and if they have not had a prior infection within the past 90 days. Infections 4 months ago or 6 months ago are just not going to have predictable immunity to prevent you from getting it. So if you're not been vaccinated, you haven't had an infection within the past 90 days from coronavirus, then if you're exposed, you need to be at home for 5 days. And then if you're asymptomatic, you're encouraged to be tested, and then you can come out and wear a mask for the additional 5 days. If somebody has been vaccinated, then they still, they don't get quarantined if they're exposed, but they still need to wear a mask, ideally be retested at 5 days, and then continue to wear a mask for 5 days after that, while watching for symptoms through the whole thing. So it's sort of the rule of fives now. If you are infected, you need to be at home for 5 days and then come out with a mask for another 5. If you've been exposed and you're unvaccinated, you need to be at home for 5 days. And then if you're asymptomatic, come out with a mask for another 5. If you've been vaccinated and exposed, then you can continue to work and do your things, but you need to wear a mask and you need to ideally be tested at day 5 and then continue to wear a mask for another 5 after that. So with all that, there have been some testing shortages. So we find that we have a backlog on testing that's being done through healthcare providers. That happens when we have a lot of strain on the healthcare infrastructure. We have lots of tests being done, and we just encourage people to be patient. There's the home tests that people can go to the store and get are in short supply. That's not just a local thing, that's a national thing. And so sometimes it's difficult to find those home tests. If someone needs to be tested and they can't find a place to test, then we ask that they act like the test is positive. So if someone has symptoms of coronavirus and they are unable to get a test to be tested, then we ask that they just act like the test was positive. They stay home for that 5 days. If they are able to improve in their symptoms, they're afebrile, then they can come back out and start circulating again and continue to wear a mask after that. We don't have an easy short-term fix for the testing shortages. That's a national issue that involves a lot of different moving parts, but hopefully that will improve some in the near future. I was also going to talk just briefly about the symptoms of Omicron. There are symptoms that are more of upper respiratory common cold type symptoms. People cannot assume that it's just their allergies that are acting up. They can't assume that they've just got a cold or that they've got the flu or they have rhinovirus. Really, we have to, right now, with the prevalence of Omicron in our community, we have to make the basic assumption that it's COVID, and only with testing can we prove that it's not COVID that's causing those symptoms. We are seeing across the country as well as locally an increase in pediatric case rates, a little bit of an increase in COVID. We have patients in the hospital and have had patients in the pediatric hospitals at both hospitals who have COVID. We also are seeing an increase in human metapneumovirus, which is just another virus that's remotely related to RSV. We're still seeing RSV. We have lots of other viruses that are going on as well. All of those things are putting a strain on the healthcare system. And fortunately, those are all things that if people are masking and social distancing, that we can actually improve the rate of infection of all those different viruses that infect and affect our children. So as we think about the coronavirus and the what's going on currently, the usual things that we keep saying: vaccination. If you haven't been vaccinated, please do so. We want people to social distance, avoid unnecessary social interactions, and please wear a mask. Thank you, David.
Thank you, Dr. Bell. Let's now go to Dr. Brian Weiss, Chief Medical Officer for Northwest Texas Hospital. Dr. Weiss, how are you?
Hey, good morning, David. Well, I have to admit, I am a bit wary that we are back in this mess again with this virus. But not nearly as wary as a lot of our frontline staff that are coming up on 2 years of battling with this thing. And now a lot of them are getting sick themselves. So, as Dr. Bell was talking about, we're hearing a lot of the stories about the increased infectivity of this Omicron variant. And that is certainly our experience at the hospital. So what we're seeing is a lot of our nurses and staff who have been in high risk situations like the ICU the last 2 years are now finally testing positive, which is incredible. It means that a lot of our mitigation strategies that were working for these last 2 years are just not nearly quite as effective for this Omicron as they were for the wild type and the Delta. Now, that being said, a lot of our staff are vaccinated. The good news is that they are recuperating from the virus without having to have much in terms of medical intervention. So again, the vaccines do help in terms of reducing some of the symptoms and the severity. To give you a sense of where we are, so back on January 3rd, so 9 days ago, we had 30 staff who were in isolation. So they tested positive, as Dr. Bell said. Today, we have 77 staff that are in isolation. So in 9 days, we have over doubled the number of our staff that have tested positive and are now out because of that. And then on top of that, just what Dr. Bell said, you add all these other viruses coming through. So we have double-digit number of employees who are calling in every day because they have flu A or they have RSV or human metapneumovirus. Just a week ago, I had a bout of strep throat. It's always good to see one of the classics come back. Hey, but we're getting a lot of people going out for multiple reasons. So this is really putting a strain on the hospitals with regard to staffing. Now, I am hopeful that this could be the last major surge we see because this thing's a wildfire. It is all over the place. I'm hoping that this may be our best opportunity to get as close to herd immunity at one time as possible. But I would double what Dr. Bell said, which is please take precautions, okay? Mask, distancing, try to avoid high-risk situations like large group meetings, things like that, because we've got to try to prevent this from overwhelming our hospitals and our healthcare system. So in terms of the numbers at Northwest, so we are at 64 inpatients with COVID this morning. Now, a month ago, that was half of that we were in the 30s a month ago. Now, out of that 64 patients, that's 13% of our licensed beds, but it's actually 26% of the patients who are currently in our acute care hospital. So as Casey mentioned, 1 out of 4 patients in our hospital right now has COVID-19 as part of their diagnosis. Again, we're seeing patients in our PDICU, in our pediatric ward, in our labor and delivery ward, in our family care unit where mothers have already had the babies. So we're seeing it spread all of our units right now. Out of the 64 that are hospitalized, 14 are vaccinated. So again, the vast majority of these patients are those that have not received the vaccine up to this point. We have 27 patients with COVID in our intensive care unit. Now, right now we're using 22 of our ventilators, and 16 of those are for patients with COVID. So again, the vast majority of our ventilator use is for patients who are suffering from COVID. Now, Dr. Bell mentioned testing, and that has been a challenge for us too. Now, back around Christmas, our testing showed typically about a 12 to 17% positivity rate. Since the beginning of January, we are now in the 24 to 32% positivity rate every day. So 1 in 3 tests are positive. About a week ago, we had one day where we did 500 PCRs for testing for COVID-19. That day, 2 of our 3 PCR machines essentially flamed out on us. So we lost 2 of the 3 machines. We had replacements, but testing's become a major challenge in the sheer volume and trying to get the testing resources that Dr. Bell was mentioning. Now, with regard to staffing, we've talked a lot about that in previous meetings. So right now we have about 45 traveling nurses coming through the RAC or the state. Because we have so many staff going out on isolation, we have actually made an appeal to FEMA at the federal level for what they call strike teams, which are teams of typically about 25 individuals that include nurses, doctors, and RTs. We don't know if we'll actually see any of those strike teams coming to Amarillo, but we certainly made the appeal knowing that we could certainly get in big trouble given the number of staff who are going on isolation. Overall, we have been on some form of diversion for over a month now every day, meaning that we are saying we don't have the capacity to accept patients from outside. This morning, we had 13 patients in our emergency room that were holding for beds. That's consistent. We're always in double digits. And we know that there are 43 patients out in the region who are waiting to get to a higher level of care, namely us, the VA, or BSA. Of those 43 in the region, half of them are people who are suffering from COVID right now. So again, we really want to try to help these regional facilities, but we've been largely stuck because of our own staffing concerns. And lastly, we had 31 individuals lose their lives in December from COVID-19. We were at 12 deaths in the month of January. So we're well on track to be another 30 plus month of deaths at our hospital from COVID-19. So again, it's unfortunate. We're back in the surge again. I do hope this will be the final one, but this one's pretty mean. This virus, this new variant is extremely infectious. So please, I beg everyone, get vaccinated, take all the precautions you can, and let's let this guy burn out, and hopefully this will be the end of these major surges. That's all I have today. Thank you.
Thank you, Dr. Wise. Let's now go to Dr. Michael Lamentier, Chief Medical Officer for BSA. Dr. Lamentier, how are you?
I'm good, David. Good morning. Thank you for letting me be on this conference today, and good morning, Amarillo. I think that it's critical to re-emphasize some of the points that have been made by Drs. Bell and Dr. Weiss to this point, and that is that we absolutely are in the thick of another surge of COVID-19. And unfortunately, it looks like it is the Omicron variant that is causing all of this frustration, angst, suffering, and death in some circumstances for patients in our community, patients across the country, and patients across the world, if you will. I saw a statistic this morning that stated that in the United States now, the 7-day average for hospitalizations due to COVID-19 confirmed or suspected exceeded 140,000. And that is a peak that has exceeded where we were a year ago in January in the United States. It's very concerning. The taxing nature of that type of hospitalization burden on our country is excessive. It's leading to significant shortages in healthcare workers in most parts of our country. And again, is part of the reason why we have been scrambling to get additional staff, including travel nurses that we are hiring and bringing on, and then also those nurses that come from the RAC and the state to support us during this ongoing pandemic. So it is very troublesome, is what I'll say. Our numbers at BSA today are starting the day with 101 COVID patients. Again, back to over 100 COVID patients is a significant burden on our hospital. We only have 309 patients in the hospital today. When I say only, I'm trying to emphasize is that a third of those are coming from COVID. So if we did not have COVID as a pandemic right now, we'd be in a much different situation in terms of the burden on our hospital and the burden on our health system. And a similar situation is happening, I know, for Dr. Weiss and his team, and for many hospitals across our state and across our country. For those patients that are in our hospital today, about a third of those, 36 this morning, are in our intensive care unit, and 28 of those 36 are on the mechanical ventilator. As we've stated to you before, when patients have to go on the mechanical ventilator now because of COVID, the risk of mortality for those patients is exceedingly high. We do have medications that we're able to use now that are better than where we were at the beginning of the pandemic, that have been shown to have some benefit in patients that have severe COVID. However, we still do not have those therapies that are curative to a high rate or that help folks avoid a severe complication. And the severe complication from COVID-19 is death. I also want to make sure that people understand that there have been a lot of ongoing commentaries about how, again, the flu is worse than COVID-19. The flu is killing more people than COVID-19 on an annual basis. The World Health Organization put out a statistic that stated that on an annual basis worldwide, we have anywhere from about 290 to 650,000 deaths from the flu every year. Those are thousands of lives. That is a high number of deaths. In the past 2 years, COVID-19 has killed over 5 million people. It's no contest. This is the reason why we're hearing about this every day. It's the reason why it's at the forefront of all of your news journals and all of the media you read, is that it is a significant problem. It is going to continue to be a problem for us, unfortunately, until we get to a point where we have some type of ability to get ahead of the various mutations that continue to evolve and combat against our therapies and our vaccines. There's just no question about that. I think that it's important for us to reiterate that vaccination still is your best method of defense. When you're vaccinated, you are less likely to have a severe complication. None of us here will tell you that you're not going to get infected when you're vaccinated. We see that. We see people who are vaccinated getting infected, absolutely. But the chance of that person going on to have a severe complication is far less. You could have a severe complication, and the statistics have shown us that if you do, and you're fully vaccinated and you end up succumbing to COVID, it's almost certainly because you have some underlying condition that caused you to not mount an appropriate and vigorous immune response with the vaccination, or you're on drugs or therapies that you must be on for certain health conditions, chemotherapy, other immunosuppressing drugs, steroids, or you have conditions that suppress your immune system. And we know what those are. So again, it's a matter of us trying to mitigate and minimize that risk for every individual in our community and every individual in our state and every individual in our country. And the way you mitigate that risk is by taking the necessary precautions, getting vaccinated, attempting to be a good steward in terms of masking when you're having any kind of symptoms that suggest you have an upper respiratory infection, whether you think it might be the common cold or you think it might be your seasonal allergies, you should assume that you have COVID-19 until proven otherwise. That's how infectious Omicron is at this time. And if you test negatively for COVID-19 and you know that you don't have it, you should still be a good steward and wear a mask when you're out in public, because when you're sneezing and wiping your nose with your hand and you're around people, they think you have COVID-19. And can you blame them for thinking that you have COVID-19? I mean, obviously, that's our biggest concern. And people are very worried about their own health status, their own immunity, and passing on this infection to other individuals. So that's just a common courtesy that I think we all have to keep in mind and continue to be thoughtful about when we're interacting with others. For some additional statistics, we are now seeing a 36% positivity rate in terms of our testing. We've had single days this month where we've been over 40% of the tests we do on a daily basis at BSA coming back positive. Those are extraordinarily high numbers, as you know. We've had about 65 to 70 patients per day coming through our respiratory triage unit. which is a separate, we call it the SOD pod on the side of our ER, which is where we do a lot of rapid testing and trying to get people a quick diagnosis of whether or not they have COVID-19 or something else like influenza. We have seen some co-infections with influenza and COVID-19. It's not a large number. It's less than 20 that we've seen as far as co-infections this flu season. But again, those do exist. And it looks like we're dealing with predominantly influenza A this year as the strain that has been most predominant. We're using about 34 of our total vents today. And again, I told you 28 of those were on COVID patients. And again, that is a significant burden on our intensive care staff, our nurses, our physicians who are managing these patients on a daily basis. And again, when you're on the ventilator and you're getting critical care with lots of IV medications and support, that's a lot of work that goes into trying to keep those patients alive. And our staff is doing a great job of it, despite the shortages that we've had. We have 80 staff members on quarantine right now. That is a very large number that jumped up dramatically for us over the past 2 weeks. And a significant number of those staff that are quarantined are vaccinated with the primary series. A smaller percentage of those are boosted. But of all those staff members that are quarantined and vaccinated, none of them had to be hospitalized. I'm not certain that would have been the same case if they weren't vaccinated. So thankfully, they are, and they're able to get through their infection and return to work when they are better. We are following the CDC revised healthcare provider return to work guidelines. And as Dr. Bell mentioned, there's a different set of guidelines for the healthcare providers than there are for the public. And remember that once you're through the abbreviated duration of quarantine, you still must be masking and taking precautions because there's still a small but possible chance that you could transmit disease beyond that shorter quarantine period. So again, that is something that we're trying to evaluate on a case-by-case basis when it looks like one of our staff is not ready to come back and we have to keep them out of work for a longer period of time. I also want to make sure that everybody understands that you may have heard that surgical cases are being delayed or postponed, maybe a friend of yours, maybe a family member. That's absolutely the case. If there are surgical cases that are not emergent or urgent, there is a assessment being done on a weekly and daily basis. I'm talking to many of our surgeons, so is our surgical leadership, our OR nursing leadership, to ask whether or not a case can be postponed. And the reason for that is that we don't have the ICU beds or the general med-surg beds to manage all of the elective surgical case volume. For those that are outpatient cases, we have a little bit better ease of doing those. But I want you to also remember that when you talk about the surgical cases that are coming to our hospitals, these are not true elective cases that folks may think of. These are oftentimes folks that have vascular problems, cancer, infectious problems, intractable pain, and things that really delaying their surgical case is not appropriate. So these are very difficult decisions that have to be made. We hate having to make them because we want to be able to have people get their procedures as quickly and expeditiously as possible. But these are some of the side effects, if you will, and difficulties with having a large COVID inpatient burden, which is what we're seeing again. So I think it's critical for us to just reemphasize that to you all. Know that our staff is going to continue to work their hardest to make sure that we're providing the best care. We are out of the monoclonal antibody at BSA and our urgent care center as well. We're hoping to get additional allocation. I would strongly recommend that you consult with your PCP, your primary doctor, if you get COVID-19 and you have some higher risk factors to see if you're eligible for one of the oral drugs now available that could help to diminish your risk for hospitalization. And there are 2 of those drugs now available. And I know that our local pharmacies are starting to get some of that supply. So again, this is a difficult time. I think we're going to get through it. We need your help. And your help is by getting vaccinated, by being a good steward when you're around your friends and community members in terms of what you're doing from your own personal hygiene and interaction methods. And we are here to help you when you do get sick. But again, our staff is working tirelessly to do so. Thank you, David.
Thank you, Dr. Lamentier. Let's now go to Dr. Rodney Gonzalez, Director of the Amarillo VA. Dr. Gonzalez, how are you?
I'm doing well, Dave. Thank you. So I'll just go right into our numbers. Currently, we have 8 COVID patients at the VA hospital. 3 are in the ICU. No one's on a vent. Now, of those 8 patients, only 1 has been vaccinated. I encourage everyone, like has been said, to, if you have not been vaccinated, to get the COVID vaccine. If you've received the COVID vaccine and you're eligible for the booster, to get the booster. The recommendations just changed after the Moderna or Pfizer. It's only a 5-month wait to get the booster. After the J&J continues to be 2 months, and you can cross. So if you got Pfizer before, you can go to Moderna or J&J, vice versa. The other thing is, and Dr. Lamentier referenced it, is we are starting to see some influenza cases. It's not, at least from my perspective, not a lot yet, but I'm sure it's going to be coming. I believe on a call I had with Dr. Bell not long ago, I think he said usually early February is when we see it peak here. So if you haven't been vaccinated for influenza, I also encourage you get that. We have the COVID and the influenza vaccine here at the Amarillo VA. So for veterans, encourage you to get those. If it's the COVID vaccine, we are vaccinating spouses and caregivers of veterans. And so with that, I just want to thank you for your time, and I appreciate this, Dave.
Thank you, Dr. Gonzalez. We'll now take questions from our media members who are in attendance. If you have a question for an individual panel member or the panel as a whole, that's completely fine. Let's go ahead and start with David Furtado of KVAI Channel 7. David, how are you today?
Doing pretty good. How about you guys?
Good, thank you.
Good. Hey, so most of my questions will be focused to Casey. I want to kind of dive into the monoclonal situation. I know that over 5,000 people have taken it, but so my question is, what does that say? With 5,000 people receiving that, what does it say about the need for the treatment, that monoclonal treatment here in Amarillo?
The need is great. I think that prevention is very important. So, we certainly need folks to be vaccinated because prevention is worth a pound of cure here. So the need is great. We still do need medication. That number exactly, David, is 5,141. So we've seen 5,141 patients since we opened on September 22nd. So lots of patients seen and lots of people treated.
And you mentioned that we're not expecting to see we're still waiting on a shipment. We haven't heard word on when we're going to get it or any confirmation about that stuff. So while we wait for the resupply, what are some of the options for folks, or is it just a waiting game? And in turn, could that waiting game increase hospitalizations? Because the monoclonal stuff, from my understanding, helps to prevent those significant hospitalizations. So could we start to see, while we're still waiting, increased hospitalizations as well?
It's definitely possible. The very best thing that we can do is to prevent getting COVID. And so the very best way to do that is to wear a mask, stay home if you're sick, if you've been exposed, stay home, don't spread it to other people. Make sure that you're vaccinated and boosted, like Dr. Gonzalez reminded us also. The very best thing to do is to prevent those infections. If you're already sick, then, lots of good supportive care, lots of, fluids, rest, but, don't lay in bed and get pneumonia. So, get up and walk around, in the backyard or in the, stay away from others, but, certainly walking around. The other doctors are welcome to chime in here, but lots of good supportive care, Tylenol, Advil, those kind of things to help your fever. And then certainly seek a higher level of care if you continue to get sicker.
Yeah. So, and I would just second what Casey's saying. We've been fortunate to be able to use the antibody infusions during the Delta surge. And I really think that given the amount of infusions that we use, we really were able to help in some ways bail out our medical system and keep our healthcare system from being overwhelmed with those 5,000 doses that we gave. That probably equals out to somewhere on the order of between 150 and 250 patients that did not get admitted to the hospital that otherwise would have. and we just flat don't have the staff to do that. Now we don't have that same availability of the medications. Therefore, it's even more important that people try to prevent getting the disease. So again, using a mask, using that social distancing, avoiding unnecessary social gatherings. This is all very low tech stuff, but it's what we got. I think that, if someone is infected, trying to be able to stay upright, active, sleeping on their belly instead of their back, all of those things are going to be things that are helpful for keeping the airway open. Making sure people stay hydrated, obviously, is important. Managing their underlying medical conditions is important. But the reality is that if we don't have those monoclonal antibodies and people are, for whatever reason, unable to access the oral agents, then we are left with these low-tech therapies, these low-tech things that people can work to try to do at home, because that's the only things that we have. And then if somebody becomes sicker, then they need to seek the healthcare, additional healthcare, and that's where our hospitals and our physicians are standing and will be able to help. But we are truly dependent on the community to really buckle down in this last surge, hopefully last surge, and help us avoid overwhelming the healthcare system.
Okay. Thank you, Dr. Bell. I also had one more quick question, again, for Casey. There are reports that 2 of the monoclonal antibody treatments are less effective against Omicron. When and Dr. Bell mentioned that we used a lot of the monoclonal stuff during the Delta surge. So when this resupply comes back, will APHD be using the one that is effective against Omicron, or are you going to be using all 3 when that resupply happens?
We will only use sotrovimab. The CDC and DSHS asked us to pause giving Regeneron and the bamlanivimab etesevimab combo because it's just not as effective against Omicron. So we've been asked to pause that. So we will only be giving the sotrovimab.
Okay, cool. And this you may not be able to answer, but I'm kind of interested in the trends. As we started to see each surge, were we seeing the similar amount of people come to the monoclonal antibody clinic, or were we seeing less folks come with every surge?
We started in September, and so it was really right in the middle of Delta, and so we have we don't have that historical data with each surge because we just started it in September. Gotcha. But we have had really a great response. It's been something that folks really sought out. So we were glad to be able to be there.
Okay, super. My last question, my news director just told me to ask you guys. Now, this meeting, is this going to be a bi-weekly meeting, or is this going to be a weekly press conference with you guys?
It will be as needed. So we will, we'll send, our communications team will send that information to you all as we have information to push out to you.
All right, super. Thanks so much for your time, guys. I appreciate it.
Thank you, David. Let's now go to Aaron Langston of KAMR Channel 4. Aaron, how are you today?
How are y'all? Good.
How are you?
Pretty good. I guess first question is, what is the concern with the hold on getting shipments of the antibodies? I know you said in the past this is a vital tool for keeping people out, and now we don't have that, and we're in a very dire situation already.
So, go ahead, Casey.
I was going to say, Aaron, I think you answered your question with your question. So you did a wonderful job there. It is a vital tool that we use to help keep people from progressing to severe disease and to prevent hospitalizations. And without it, Dr. Bell did a great job describing why it's so critical. But the prevention of COVID is just as critical. So we are waiting for our next shipments, and we definitely look forward to that and look forward to starting infusing again. But you did a great job asking and answering your question.
Yeah, I would just offer the analogy. In my barn, I've got nails and I've got screws. And if I run out of screws, then I use nails. And I think that we've got monoclonal antibodies, and we've got prevention measures like masks and social distancing and vaccination. And when we run out of monoclonal antibodies, we need to be using the nails. And so, again, this doesn't mean that we're helpless in the face of this. We still have things that we can be doing. We control our own destiny, if you will. But it really does require the community as a whole coming together and doing the right thing.
All righty, thank you very much. And you mentioned earlier that some of the symptoms for the Omicron are slightly different than what we've seen in previous variants. Can you tell us some of the differences in the symptoms that we're seeing?
Sure. So the one of the things that we saw with a lot of the earlier variants was that a significant portion of the people lost their sense of taste or smell. That is much less likely to happen with Omicron. And I can't remember the exact number. I want to say that somewhere on the order of only about 10 to 15% of people maybe lose that sense of taste or smell. So people should not say, boy, it's my allergies until I lose my sense of smell. They're going to potentially spread Omicron a lot before they get a diagnosis. We see that folks with Omicron as on an individual basis are more likely to have mild upper respiratory symptoms, a little bit lower risk of fever, having more runny nose, nasal congestion, those type of things that we might typically associate with just a run-of-the-mill cold. And the issue or the problem, of course, is that, as we mentioned, it's very difficult then to differentiate between seasonal allergies and rhinovirus or some other run-of-the-mill cold virus and Omicron. Now, for any individual patient, their risk is only about a third of what it would have been with Delta, that they would end up being hospitalized. But given the transmissibility and infectivity of the Omicron, we're seeing these massive number of people being infected. And as we get those massive numbers of people infected, even if only a third of people are going to be hospitalized compared to Delta, we're still seeing lots and lots and lots of hospitalizations. And we still have today, I've got a 30 some odd year old, a 20 some odd year old, and a 40-year-old that I'm taking care of in the hospital today who have COVID. And even in those young age groups, only one of the three actually has any risk factors that would put them at increased risk. So again, we're seeing that it can definitely affect the young people. It can affect the old people. And so even though it may be mild in some people, it doesn't mean that it's mild in others.
Aaron, I would just say anecdotally from my experience, a lot more people are complaining of sore throats with this guy. And I think that may be what Dr. Bell is talking about, just that post-nasal drip that this produces. But it's interesting, I've not heard sore throats with the previous variants, but this guy is.
All righty. And are y'all seeing a higher number of false positives or false negatives with this one versus the others?
So it's hard to answer that on a statistical standpoint because we don't have another gold standard necessarily to compare that to. So what I'd say is that from a biological plausibility standpoint and from an anecdotal standpoint, the more home tests we do, the more likely we are to have false positives. Those home tests, they're great. I think that they've really got a role. They tend, though, not to be as vigorous of a sample collection technique as if somebody was doing a test at the doctor's office. Even at the doctor's office, the antigen tests are going to have a higher false negative rate than the PCR test. The PCR remains our gold standard. And so we do think that as we start depending more on these other testing mediums, that we probably will see more false negatives. More concerning than that to me, though, would be that people are not being tested because they think they've got seasonal allergies, or they want to be tested, but they can't find a test. And so that's where I think that if we can be aware that those mild symptoms still could be Omicron, and until somebody's able to get tested, they need to treat it as if it was Omicron.
All righty. And Dr. Weiss mentioned earlier requesting help from FEMA on the strike team. What other options are you guys looking at to supplement staffing needs with the quarantine numbers and just the influx of patients?
Yeah, Aaron, I would just say there's really only really three options. One is the RAC that's been very good to us over the last 2 years. That's the state, but they've really said that they're very limited at this point on any further staffing. Obviously, there's the federal government like FEMA, but they they were actually pretty realistic, saying that they are getting flooded with appeals similar to what we've done in Amarillo here. So they couldn't really assure us. And then there's the private staffing agencies that Dr. Lamentier and I have talked about, the normal nursing staffing agencies. And there too, a lot of them are tapped out in terms of being able to offer additional nursing staff. So that's really where we are. Those are the three sources we can find, and none of them are proving to be a consistent or reliable source of additional staff.
That's correct. The same thing at BSA. I mean, again, the bulk of staff that we have to help with this surge, besides our core staff, obviously is the bulk. But as far as additional assisting staff would be travel nurses that we have personally hired to come and help with staffing. Then beyond that is the RAC staff. Right now, today, as far as our numbers, we have 105 travel nurses that we have hired to bring on to help at BSA cover our shifts and critical units. We have 58 RAC staff in addition to those 105. So you can see how that significant number of additional staff beyond our core staff is necessary now to keep open our beds and continue to manage the number of patients that we're seeing on a daily basis.
All righty. And is there any concern right now possibly having to pull staff away from I guess the normal patient care and reassign them into a COVID situation?
Yeah, I think that there is that concern. And again, there's a situation that could occur where we are looking at team staffing models where we have nurses that are not trained to do ICU care, but are trained to do general med surg care, assist a core team of ICU nurses. And again, have that team model approach. We have not done that yet at BSA, but certainly that would be a possibility if we got more taxed in terms of not having enough staff and we did not get more help from the state or elsewhere. So again, those are the types of things that we're contemplating. And I know that other healthcare systems within our system, our Ardent Health system, are doing across the country, and also other health systems across the country outside of ours.
Yeah, Aaron, I was saying the same thing at Northwest. One issue, everything is, nurses in hospitals play an abundance of different roles. So we have a lot of nurses that are part of our quality department, our risk department, and these are supportive roles. And a lot of these nurses have developed a skill set that's very different than the bedside nurse over time. And there's always been a suggestion of maybe some of these nurses can go back to work at bedside, but that's a big jump. A lot of these individuals really have developed a whole different skill set. So it's again, while we may have nurses playing roles in the hospital, bedside nursing may not be they're really focused at this point.
All righty, I think that has me covered. Thank you all very much.
Thank you, Aaron. Let's now go to Michael Caviello, a reporter for the Amarillo Globe News. Michael, how are you today?
Can you hear me now?
Yeah, we got you. How are you, Michael?
I'm doing very well, and glad to be here with you folks, even though we're still talking about things that people would rather not speak about. Question on the home test. Okay, so normally we have a way of tracking how many positive tests we have. Is there some type of concern with the home test that we're really not going to get the data of how COVID may be impacting the community?
Yeah, Michael, I think that's a very good point, and that's something that's been looked at or discussed on a local level, on state level, on a national level. The short answer right now is that there's not a way to be able to track those home tests. And we would rather people be testing, and we're trusting that people are going to do the right thing once they have done the test. That individual responsibility, that's really where that comes into play, because there's not anybody that's going to call them and say, hey, listen, I heard you tested in your kitchen and you're positive. There's been discussion at a national level, I think, about some mechanism for people to be able to report that. I believe one of the states up in the Northeast has actually implemented a pilot program in that regard. But the fact is that those home test results are just not going to enter our numbers based in the current system. So what we're seeing right now with the surge that we've had in community transmission is undoubtedly a significant undercount of what is occurring across the community at large because it doesn't take into account those home tests.
And then I've read that there's a new vaccine, well, mostly targeting like how Omicron is going to be. So does that mean many people that have had boosters will probably have to have another type of booster because of the way it's been targeted, or they just have faith that it'll be good enough as is?
I think that's I'll start and let Todd add on there. I think this is a situation that's going to be continually evolving. And I think that we're going to have to hope that our scientists continue to do what they've been doing across the country and across the world, which is try to base some of these decisions on data that we get back that show how effective the current vaccinations are. So again, one thing I think we should expect is going to happen is that the virus is going to continue to mutate. The question will be, will new mutations be more infective, less infective, more virulent, or less virulent in terms of causing severe disease or not? And then again, if we're seeing that people are getting infected and not having severe complications if they're vaccinated, that's still a big win in terms of being vaccinated. Again, I would say that that would be somewhat analogous to the flu vaccine, which we know doesn't prevent you 100% from getting the flu, but it certainly helps to prevent you from having a severe complication from the flu. So I think it's very analogous to that. I think it's also a situation where it could be that we have an annual or maybe less frequent need for recurrent vaccination to keep us ahead of those potential severe complications. But again, those decisions should be based on data. And I think that's what our scientists are trying to do and are hesitant about predicting too much because they're waiting on the data.
And I guess we're talking about the antibody treatments that were short. I'm assuming it's somewhat an over-reliance that we've had to have on the antibodies. And also maybe since Omicron is not, two of the ones are not as effective. Is that another reason that we may have a shortage on the antibodies?
Well, yes. I mean,
go ahead, Todd. No, you aced the last question.
Yeah, I think that you're absolutely right. I mean, no question that because of the lack of efficacy that we are now seeing with Regeneron and the BAM-EDI on Omicron, yes, we've had to rely on the newer drug called sotrovimab, which does have good efficacy, but we don't have the production available to have that be readily available for everyone. Fortunately, since the outset of the pandemic, however, those two new oral drugs are available that can be prescribed. Are they as effective as the IV monoclonals? Well, I think, again, it depends on the drug you're talking about and depends upon the studies you're looking at. They look to be fairly successful in terms of preventing severe complications. The problem is one of the drugs you have to be careful with for folks that are on a lot of other medications that are metabolized by a certain pathway in the liver, and that can be a problem if you're being prescribed one of those drugs. And secondly, again, these are not magic bullets. They're not going to be successful in all patients, but I do think there are other tools in the toolkit to help us with combating COVID-19. And again, I will go back to this. The longer we have, the number being high, and the longer we have folks that have no immunity and continue to get infected and spread this to other folks, whether it be a lack of natural immunity or a lack of vaccinated immunity, the greater chance we're going to have of the virus lingering around with us and causing problems. So how do you get immunity? The safe way, you get vaccinated. And that's how you help to all of us to combat this virus. Don't roll the dice and say, well, I'll get infected and that's how I'll get my God-given immunity. Yes, we all have some God-given immunity, but God's also given us the brains to develop vaccines that are helping to save lives. This is 2021. Science is a big part of what we do. And so is faith in science and faith in the individuals who are helping us develop these tools in our toolkit. Being someone of faith doesn't mean that we abandon science.
And this would just be my last question. Okay, so we're waiting on new antibodies, and we keep talking about masking and all this, which is great. But as you walk around the Amarillo community, it's not a surprise that we have the hospital rates that we have, because the only people I truly see masking are the people that are being forced to mask as far as employees. You see like one person out of a whole store masked. So is there a concern that because of the shortage of antibodies, that the surge may even surge more?
Yes, I think that's why we're having this press conference.
Yeah. Well, I like that. It's a nice, short, and simple one. I just want to ask a quick question. Are the hospital rates that we have now higher than a few years ago? Because the reason I ask is because a lot of people say hospital occupancy is the same, and I don't have that data in front of me. So I just kind of want to have y'all, somebody answer that, just because I hear that a lot in the community.
So, Michael, I know at Northwest, no, it's not as high as it was at the peak of last winter. Okay, I mean, we were up into the 90s or the hundreds. The difference, though, is at that time we had a bunch of RAC traveling nurses, so we had a huge capacity because of these nurses that the state was bringing in. We do not have those nurses now nearly as to the level we did a year ago. So that's why we're finding that even at lower numbers right now of COVID patients, we are probably in a more challenging state right now with regard to bed capacity than we were a year ago. So that's the difference, is the staff is really the change.
I kind of ineloquently asked that. I meant prior to COVID.
I would say in terms of prior to COVID, I guess in terms of our acute side, we are comfortable at numbers of 240 to 260 patients most of the time. That's when we have our full employed staff. I think today we were at 246, and that's put a big strain on us. That's why we have the hold. So yes, 2 years ago, 246 would have been a comfortable position because we had all the employed nurses we did. Now that we've lost so many of those nurses and we've got a bunch of sick nurses in isolation and sick for other reasons, 246 is a major challenge today for us.
Thank you very much for your answers.
Thank you, Michael. Let's now go to Kevin Welch of News Channel 10. Kevin, how are you today?
I'm good, Dave. Thank you. Casey, can you speak to the demand for testing at the city site and the availability of supplies to meet that demand?
Yes, demand has increased dramatically and our supplies are holding out sufficiently.
Okay. And Dr. Bell, can you kind of look in your crystal ball and give us your best take on where the amount of infections is going to go from here?
I threw my crystal ball in the trash about 8 weeks ago because it seems to be broken. I think that, given the rate of rise that we're currently seeing, we likely are going to hit our peak sometime before the 1st of February. So sometime within the next 3 weeks. And after that, I don't have a good feel for what the tail of the epi curve is going to look like. It seems like if you look at South Africa and some other places that have already been through their Omicron wave, that the tail drops more rapidly just because you have so many more people that are infected on the front end. The thought would be that, or the guess would be that we probably are going to hit our peak within the next couple of weeks. That's good because it means that February, March, April, hopefully we'll have much lower numbers. It's bad because it means that all the work that we might have done in January, February, and March in a spread out surge is done in the next 21 days.
Okay. And I'm not sure who to ask, if it's you or Casey, maybe. Is there a way to characterize who is dying? Because we've been getting these spurts instead of just 1, 2, 3. Who are the patients who are dying?
So from a basic demographic standpoint, the health department actually on our website actually has where it breaks it down by I believe gender and then by age category. So 0 to 10, 11 to 20, that type of breakdown. As far as other demographics, I'll defer to Casey. I'm not sure that we have good data on the other demographics.
And I may have to defer to the hospitals. I'm so sorry to do that, but
Yeah, I can put a comment here. I've asked our QI team to pull together some data on all of our mortalities that we've had at BSA, just so we could further review the characteristics of those patients. And I'll say first thing is that looking back and I had a discussion with Dr. Bell about this, and we were talking about trying to make sure that we want to report our statistics accurately. And I think it's a good discussion. But it looks like if you take a weekly look at our inpatients and do a daily snapshot, anywhere from 82% up to as high as 99% of the people we have in the hospital with COVID-19 at any single day are not vaccinated. Then if you look at those individuals that are in the intensive care unit, that percentage is higher, gets closer to 90%. And then if you look at those that go on the ventilator, it's higher, above 90%. And again, those that are unfortunately succumbing, the number again is in that 85 to 95% range are not vaccinated. So that's the first, I think, lever that you have to understand. People that are not vaccinated are at higher risk of having a severe complication. The second thing I would say is when I looked at those that are vaccinated and saying some of these folks are vaccinated and they're still getting sick, and some of them, unfortunately, are dying. And when we look at those characteristics, those individuals tend to have significant illnesses, like I mentioned, heart disease, diabetes, chronic kidney failure on dialysis, immunosuppressing conditions like cancer and chemotherapy, transplant patients. So again, that tends to be the look, but there are the occasional patient that we look at and we say, I don't understand this. This is a young person that has no health problems. They got vaccinated and they have succumbed to the disease. And I think those are the ones that scare us the most and we can't explain, but I would have to think that it's that person's idiosyncratic genetic makeup and their inability to mount a good immune response, and therefore they have succumbed.
Okay. And Dr. Lamantier, Dr. Weiss touched on his emergency room traffic. Can you tell us what it's like at BSA?
The ER is a very overwhelmed place right now. Our staff is working tirelessly. We have situations where they're trying to manage admitted patients at a really inappropriate and unacceptable number and level. What I mean by that is our ER nurses and staff should be able to quickly treat and triage folks. And when they need to be admitted, give the initial therapies that allow them to get upstairs to our admitting units. But when the admitting units don't have beds and don't have staffing to take care of those patients, they stay in the ER. So when Dr. Weiss and I tell you that we're have all these ER holds, that means those are 18 people at BSA this morning that were admitted but had to sit in the ER because we didn't have a bed upstairs. And then the ER nurses are the ones trying to manage those cases. And the ER nurses are not equipped always with the support staff and the things they need to be able to do that well. And that is the difficult part. And that's what's causing folks to burn out. It's causing folks to really say, we need more help. And they're exactly right. We need more help. And it's a problem. The ER is seeing about 180 to over 200 patients a day. We are testing patients by the droves. We are admitting patients by the droves. Anywhere from 25 to 35% of the people we see, we end up admitting. And that is a significant workload. So you ask me how we're doing. We're not doing well in our ER. We are struggling. And if you ask me about our urgent care center, we're getting overwhelmed there as well. We've had days where we've seen over 200 patients in our BSA urgent care center. That's as high as the volume in the ER. And yes, most of it's respiratory illness. So again, the burden is significant. We wouldn't be on this press conference just to tell you things are okay and things are going well. They're not going well. And that's what our concern is.
Okay, thank you. Everybody hang in there. That's it.
We
Let
appreciate
me
it.
just add that the confirmed deaths and confirmed cases by age have been available on AmarilloAlerts.com. That's been on the dashboard for quite some time. But it's one of
Yeah,
the,
I was asking about the past like 2 weeks, that those numbers cover the whole range of COVID.
yes, but that's been on there for a while. But I just, in case anybody wants to know, it is on AmarilloAlerts.com in case anyone's looking for it. Okay, that concludes our public health update for today. I want to thank all of our panelists who took the time to provide this information to the Amarillo community. Thank you for your participation today. This is David Henry, Communications Manager for the City of Amarillo. We'll see you one next time. Thank you.
Thank you.